Good day, ma'am. This is Michael Therese Portillo Rosales, and I'll be discussing about the types of hemolytic anemia. To start with, what is hemolytic anemia? So, hemolytic anemia is a disorder in which RBCs are destroyed faster than they are made. The destruction of RBCs are called hemolysis. There are two types of hemolytic anemia: acquired hemolytic anemia and inherited hemolytic anemia. Symptoms of hemolytic anemia: abnormal paleness or lack of color of the skin, yellowish skin, eyes and mouth for jaundice, dark colored urine, fever, weakness. So there are several diseases that causes this condition: enlarged spleen, infectious hepatitis, EBV, typhoid fever, E. coli toxin, leukemia, lymphoma, medications that causes hemolytic anemia: acetaminophen, antibiotics such as penicillin, interferon alpha, procainamide, quinidine, and rifampin. The types of hemolytic anemia. First off is hereditary spherocytosis. What is hereditary spherocytosis? Hereditary spherocytosis is a very heterogeneous form of hemolytic anemia, transmitted in the majority cases as an autosomal dominant trait. It is the most common prevalent hereditary hemolytic anemia among people of the Northern European descent. It is not restricted to any single race. Manifestations of the disorder range from almost normal carriers of the trait to cases of severe hemolytic anemia. Anemia may manifest itself anytime, for early infancy to later life. There are four forms of hereditary spherocytosis. Mild form, 20 to 30% of people with HS. Moderate form, 60 to 70% of people with HS. 10% has moderate or severe form. And 3 to 5% have severe form. Hereditary spherocytosis is a very heterogeneous form of hemolytic anemia, transmitted in the majority cases as an autosomal dominant trait. It is the most common prevalent hereditary hemolytic anemia among the people of Northern European descent. It is not restricted to any single race. Manifestations of this disorder range from almost normal carriers of the trait to cases of severe hemolytic anemia. So, anemia may manifest itself anytime, from early infancy to early adulthood. So there are four forms of hereditary spherocytosis. Mild form, 20 to 30% of people with HS. Moderate form, 60 to 70% of people with HS. 10% have moderate or severe form, and 3 to 5% have severe form. There are four forms of hereditary spherocytosis. Mild form is at 20 to 30% of people. Moderate form is at 60 to 70% of people. 10% have moderate or severe form. 3 to 5% have severe form. The underlying abnormality is a defect in the interaction between the cell membrane skeleton and the bilayer. The defect mainly involves decreased proteins linked to spectrin acrinin band 3, associations, and weak contacts between spectrin and negatively charged lipids of the inner half of the membrane bilayer. Mutations in the ANK1 gene is responsible for approximately half of all the cases of hereditary spherocytosis. The other genes associated with hereditary spherocytosis each account for a smaller percentage of cases of this condition. Mutations in red blood cell membrane proteins result in an overly rigid, misshapen cell. Mutations in the RBC membrane proteins result in an overly rigid, misshapen cell instead of a flattened disc shape. These cells are spherical. Dysfunctional membrane proteins interfere with the cell's ability to change shape when passing through the blood vessels. These misshapen RBCs, called spherocytes, are removed from the circulation and then taken to the spleen for them to break down. So within the spleen, the RBCs break down, so they undergo hemolysis. The shortage of RBCs in the circulation and the abundance of cells in the spleen are responsible for the signs and symptoms of this condition. For the signs and symptoms of hereditary spherocytosis, we have anemia, paleness, jaundice, intermittent jaundice, enlarged spleen, and gallstone development. For laboratory tests, we do CBC, reticulocyte count, MCHC, peripheral blood smear, lactate dehydrogenase level, fractionated bilirubin level, osmotic fragility test, direct antiglobulin test. Hereditary spherocytosis is most often diagnosed in childhood or early adulthood. In about 3 out of 4 cases, there's a family history of this condition. For the treatment of hereditary spherocytosis, sadly there is no treatment. But for the prognosis for a person with spherocytosis is good to fair. And most individuals will have a normal life expectancy. Individuals that have spleen and or gallbladder removed may have fewer complications, develop and have abnormal spherocytes, survive and function longer, thus requiring few transfusions or other interventions. For hereditary elliptocytosis, defects are in the structure or quantity of the cytoskeletal proteins, so responsible for maintaining the biconcave morphology of RBC. Mutations in either alpha and beta spectrin are most commonly responsible, but mutations in other cytoskeletal proteins are also described. Elliptocytes are elliptical shaped or cigar shaped, elongated oval RBCs. So they are seen in hereditary elliptocytosis, IDA, megaloblastic anemia, myelodysplastic syndrome. For occurrence, in the United States, hereditary elliptocytosis has a prevalence of 200 to 500 per million population. International, hereditary elliptocytosis has worldwide distribution. Race, sex, and age demographics, the incidence of stomatocytic elliptocytosis among Malayan Aborigines is 30%. Neonatal poikilocytosis occurs mostly exclusively in African American families. Spherocytic elliptocytosis most commonly affects individuals of European descent. Hereditary pyropoikilocytosis, a related condition, is caused by 2 mutations in these genes. Hereditary elliptocytosis results from defects in the protein scaffolding of the erythrocyte membrane, which decrease the deformity. Allele alpha is a common polymorphic allele which plays a role of an aggravating factor when it occurs in strands of an elliptocytogenic allele of an SPTA1 gene. Southeast Asian ovalocytosis results from a 27 nucleotide deletion in the LC4A1 gene. Besides these conditions, in which the mutations were reached from known alterations in the proteins, other conditions required a positional cloning approach, such are the genetic disorders of membrane permeability to monovalent cation. The signs and symptoms of hereditary elliptocytosis are fatigue, shortness of breath, yellow skin, and eyes. For the laboratory findings, the following tests may help diagnose the condition: increased bilirubin levels, elliptical RBCs in blood smears, increased lactate dehydrogenase level, and gallstones. The diagnosis of hereditary elliptocytosis is usually made by a coupling of family history of the condition with an appropriate clinical presentation and confirmation on a blood smear. So in general, it requires that at least 25% of RBCs in the specimen are abnormally elliptical in shape, though the absorbed percentage of the elliptocytes can be 100%. This is in contrast to the rest of the population, in which it is common for up to 15% of RBCs to be elliptical. Definitive diagnosis can involve osmotic fragility test, an autohemolysis test, and the direct protein assaying by gel electrophoresis. For prognosis, asymptomatic patients require no treatment. All HE patients who are significantly anemic and show signs of hemolysis respond well to splectonomy. transfusions are occasionally needed for life-threatening anemia. Those with hereditary eleptocytosis have good prognosis, while only those with severe conditions have a shortened life expectancy. Hereditary stomatocytosis comprises a group of heterogeneous conditions in which RBC membrane leaks monovalent cations. The two major categories are overhydrated hereditary stomatitis and dehydrated hereditary stomatocytosis. Overhydrated hereditary stomatocytosis, a very rare hemolytic anemia due to a defect in membrane cation permeability that causes the RBCs to be overly hydrated. Dehydrated hereditary stomatocytosis, an autosomal dominant hemolytic anemia due to a defect in membrane cation permeability that causes the RBCs to be dehydrated, the most common form of stomatocytosis. For etiology, the most cases or the majority cases of OHS is caused by mutations in the RAG gene, encoding the Rh-associated glycoprotein component of the Rh complex. So the most reported DHS conditions are caused by gain of function mutations in the gene PIE-Z01, which encodes part of the mechanosensitive into the channel. This results in increased red cell membrane permeability for cations that consequently leads to a cation depletion, dehydration, and shortened red cell survival. Rare atypical forms have been associated with mutations in SLC4A1, coding for the band 3 anion transport protein, or KCNN4, which codes for the putative Gardus channel. So the gene, RHAG gene, the protein encoded by